Representative Fraser Gordon.
Present in the room.
Thank you. Representative Marzian. Here. Thank you. Representative Gibbons Prunty.
Present in the room.
Thank you. Representative Rayburn. Representative Raymond. Representative Riley. Representative Sharp.
Present in the room.
Thank you. Representative Sheldon.
Glad to be here.
Thank you. Representative Tate. Representative Weber. Representative Westrom. Representative Wilner. Chairwoman Mosier.
I am here.
Wonderful.
Okay, we have a quorum and our... Oh, thank you.
As well as Representative Bowling, please.
Okay.
Thank you.
Okay, perfect. So we have a quorum established and are prepared to do business. We have some special guests with us today that I would just like to make a few introductions. I have some constituents with me today, Tom and Dana Kohler. Thank you very much for being here. If you can just wave your hand. Thank you. And we have a lot of distinguished guests with us today who have flown in and come in to speak on some very special bills, important bills this morning. And everyone will obviously introduce themselves later, but I was pleasantly surprised to see my good friend, Dr. Mike Gieske, here with us this morning, so thanks for being here. Do we have any other introductions? Okay. I think we will go ahead and get started since we're busy running between committees. We will call up House Bill 188, Representative Duplessis, and if you have any guests with us, please introduce yourself for the record and please proceed.
Thank you, Chairwoman Moser. I'm Jim Duplessis, District 25 State Representative out of Hardin County. On the Zoom call, we have Dr. Cheryl Levinson, PhD, Associate Professor at University of Louisville, and also founder of the, I'm going to mess this up, the Eating Disorder Clinic in Louisville, Kentucky. Dr. Levinson, would you like to introduce yourself?
Sure. Hi, everyone. I'm Dr. Levinson. As said, I'm faculty at University of Louisville, where I direct the Eating Anxiety Treatment Research Lab, and I'm also founder and clinical director at Louisville Center for Eating Disorders, which is the only eating disorder specialty clinic in the state of Kentucky where we offer a higher level of care and outpatient services. So excited to be here today to talk about expanding access.
Thank you, Doctor. The reason I'm here is I had a constituent come to me whose child was receiving services from the clinic in Louisville. Said child was with the family on vacation. I don't know if they had an anxiety issue or what, but needed to talk to their counselor. But the counselor was like, we're not allowed to do over state lines telehealth. So they've taken a hard position that they don't want to risk their licensure. So they don't do anything telehealth for mental illness. And as we know, mental illness, especially with COVID, has taken the forefront because we've seen just how important mental illness and its care is. So whether you're somebody who's suicidal or you're anorexic or whatever it might be, if you need to talk to your counselor, we need to make sure as a state that we've made that able to be done. And this bill does that. In a nutshell, it's a really simple bill. It says that the counselor, or excuse me, not the counselor, the practitioner, whether it's a doctor or therapist, they must be licensed and certified in the state of Kentucky. They can't be, and the patient must be a permanent resident of Kentucky, and that resident, if they are temporarily out of state, they can receive services. So that's basically, in a nutshell, what the bill does. It has reciprocity for other states in it as well. So
motion on the bill.
Okay, we have a motion and a second on the bill. Do we have any questions? Representative Sheldon.
Just quickly, I want to thank you for making yourself available to, I'm sure, everybody on the committee and answering some questions. And the fact that there's no opposition here at all makes this this bill look like something we definitely need. So thanks a lot for allowing us to engage prior to this even. Thank you very much.
Thank you, Representative.
Thank you. And I appreciate this clarification. This question has come up, and I think it's a very good fix. So thank you for working with us on this through the summer, and I appreciate this legislation. Secretary, please take the roll.
Representative Bentley? Representative Bowling?
Yes.
Representative Bray? Representative Birch? Representative Dotson?
Yes.
Representative Elliott? Representative Fleming? Representative Frazier Gordon?
Yes.
Representative Marzian? Representative Gibbons Prunty?
Yes.
Representative Rayburn? Representative Raymond? Representative Riley? Representative Sharp?
Yes.
Representative Sheldon?
Yes.
Representative Tate?
Yes.
Representative Weber? Representative Westrom?
I'd like I'd like to make a comment, and that being that the acceptance, because of COVID, of the mental health industry and the importance in our country is one good outcome of a horrible situation for the past 2 years. So I thank you for the work you're doing, and I vote yes for this.
Representative Wilner? Chairwoman Mosier?
Yes.
Wonderful.
House Bill 188 passes with favorable expression. The same should pass on the House.
I
Congratulations.
would like to
and
thank this committee and the chair for working with me on this. Thank you so much.
Thank you. Okay, we do have House Bill 92 on the agenda, and just to let members know, we will be passing over this today because there was a committee sub in the works, and the Attorney General still had some questions to work through with some of the stakeholders. So expect to see that another time, but not today. I will be passing the gavel to my co-chair and coming to the table to present two bills today. House Bill 219 will be the first bill that we take up, lung cancer screening. So if my guests could please make their way to the table.
Please introduce yourself for the record, and you may proceed.
Thank you, Madam Chair. I am Representative Kim Mosier, representing the 64th District, and I am pleased to have some esteemed guests with me this morning, and I will have them introduce themselves. We also have a guest online, Dr. Douglas Flora, and just to go ahead and get us started,
Do you want to go ahead and address
adopt
the
the
committee,
committee sub.
We have
Yes.
a committee sub.
Mm-hmm.
Do I hear a second? Second, having a second. Voice vote. All in favor say aye. Opposed? You may proceed.
Perfect, thank you. So yes, we will be working from the committee sub, which just adds or actually pulls out some language having to do with prevention. We found that it was a little confusing to have prevention in this bill when we have other prevention, tobacco cessation programs in Kentucky, and this really pertains only to lung cancer screening. So 219, House Bill 219, is a bill implementing and establishing a lung cancer screening program. Kentucky is #1 in the incidence of lung cancer and in the nation, and has a correlating low level of early detection. This is why this bill is just so critical. It's modeled after the colon cancer screening program that we put in place in Kentucky, and we've seen great results from that, seeing our colon cancer screening rates really increase and early detection rates improve. So this is modeled after that provision. Lung cancer screenings can detect lung cancer earlier when treatment is most effective. Survival rates are surely improved when that happens. So again, I have some guests with me, and I will allow them to introduce themselves and answer any questions. But what this legislation does simply is establishes a restricted fund for the assistance of any eligible Kentucky resident for lung cancer screening. And then it establishes a lung cancer screening advisory council, including experts and stakeholders, to review relevant data, clinical guidelines, and best practices for lung cancer screening, and also provides oversight and annual reporting on the implementation and outcomes. So I will hand it off to whoever wants to go first.
Sure, I'd be happy to get started. Chairwoman, thank you very much for the opportunity. My name is Tim Mullett. I'm a professor at University of Kentucky in cardiac and thoracic surgery, and a thoracic surgeon operating on lung cancer here in Kentucky for over 25 years. The work that we've done at Markey Cancer Center has been successful to be able to enhance the quality of lung cancer surgery. And while we are often successful with our operations on early stage lung cancer, surgeons are universally frustrated by the fact that only 15 to 18% of lung cancer are discovered in that early phase. And so, as mentioned, the opportunity to be able to have more success with treating patients at an earlier stage is optimal. It's also less expensive. It doesn't involve getting into the costs of the later stage drugs and more extensive radiation therapy and other treatments. And so, unfortunately, Kentucky does lead the country in mortality from this disease. And up until last year, we were leading the country in incidence for this disease as well. Now we are number 2, and that's progress for us. In a state that has borne the burden of lung cancer for so long, it is nice to see some movement in this. And unfortunately, the leading cause of mortality is the fact that the majority of our patients, much more than the rest of the country, are seen with late-stage disease over 80% of the time. We have a chance to change that. Lung cancer screening can be effective and can reduce mortality by as much as 20 to 50%. And so nothing stands out in terms of medications or other treatments that can make a difference other than that stage shift. Across the country, screening rates remain low, around 6% for eligible patients. Those people that meet the specific criteria for qualifying for a low-dose CT scan can participate in this, but this number pales in comparison to that of breast, colon, cervical cancer, which have been much more successful over time. With as much cancer as we have in Kentucky, we don't have time, and we need to accelerate our movement of lung cancer screening. Since 2015, I and many colleagues, led by Markey Cancer Center, colleagues like Dr. Giese, Dr. Flores' program, folks across the state and many community programs have participated in a research project called the Kentucky Leads Collaborative, and this has helped us to be able to drive Kentucky screening rates to the number 2 in the country. Second in the country, something that Kentucky doesn't normally see in the rates of lung disease or in cancer activity. So this is huge. We've gotten almost to 20%. That's not enough. We can do better. Unfortunately, that rate of 20% is not evenly distributed across the state either, and so we need to address disparities that are becoming apparent in lung cancer screening. And this tool, House Bill 219, is a tool to be able to make that change. Lung cancer screening has been proven to be effective. It can fight our lung cancer screening rate, and it's only been active for less than 10 years. And so we've already seen a 10% reduction in late-stage diagnosis. That's something that we haven't seen ever. And so it's beginning to take effect, but it's not evenly distributed. We need to be more effective at getting improved access to lung cancer screening, and most importantly, defining the quality of lung cancer screening. I think we have a chance to take the science that we have developed over the past several years and use the lessons learned from that data to be able to apply it through the advisory board in an effective way to be able to increase the quality of lung cancer screening for our Kentuckians and increase the access of lung cancer screening. Your support will help keep Kentucky as an effective leader in the management of this disease. Representative Birch.
Thank you.
Sorry, it's not me.
What I'd like to say, this is legislation being proposed just like we did the colon cancer legislation, which I'm proud to say I was the sponsor of that. Kentucky was one of the leaders in colon cancer deaths until we actually passed this legislation, and now we've reduced that considerably. And this legislation, if it's done the way it's supposed to be, like the colon cancer thing, I think you'll see a great reduction in lung cancer deaths and early detection. And you're right, Kentucky is one of the worst states. And you didn't mention the fact that we have that dirty habit of smoking that causes a great deal. Now I know my son is a victim of that there, and fortunately he's in remission right now. And I had a doctor friend of mine who would tell his patients to stop smoking, then he'd light up a cigarette before they left the room. He died of it at 40 years old. So this is good legislation, and I encourage the members to vote for it and pass this legislation. Thank you, Madam Chair.
Representative Mosier, do you want the rest of your folks to testify? Okay, thank you.
Yeah, I can go ahead and I'll go next. I'm Dr. Michael Gieske. I'm a family practitioner. I've been in practice for over 35 years now, and I grew up in Edgewood, Kentucky, right at the site of our flagship hospital, St. Elizabeth Edgewood, where we have a beautiful new state-of-the-art cancer center. I was asked to join our thoracic oncology disease management team in 2016 as the primary care representative. At the time, I had never heard of a low-dose CT lung cancer screen. And American Academy of Family Practice, just as of April of last year, recognized lung cancer
Can
screening.
you pull your mic closer? People are having trouble getting
Sure.
on the recording.
Sure. Just as of April of last year, the American Academy of Family Practice recognized lung cancer screening as having some value. So we had that to work against as a barrier. But since that time, we've made really fairly considerable progress. For 3 decades, I dealt with lung cancer patients that presented to my office with this dismal prognosis. And there was a sense of helplessness and hopelessness for both myself and my patients and their families as well. We now have a mechanism to go after lung cancer, to find it in the earliest stages with a low-dose CT lung cancer screen. If we find lung cancer in the earliest stages, stage 1, we have a greater than 90% chance of curing that cancer. We have patients with stage 3 and stage 4 lung cancer now, even when we find it in these later stages, that have been alive for 10 to 15 years with no evidence of disease. So even when we find lung cancer in the later stages, we can make a dramatic difference. At St. Elizabeth Healthcare, we've built quite an impressive team. It's been a collaborative effort. We have as a foundational component of our screening program the Nodule Review Board. It's made up of a pulmonologist, a radiologist, and a thoracic surgeon. I'm there. We have 2 nurse navigators. We meet every Monday morning bright and early at 7 a.m. We review all of the suspicious scans from our program and the incidental scans that come in as well that are suspicious. The nurse navigators are a critical component of this. We consider them the glue for our program. They really help to guide the patient through every step of the process. They communicate with the providers and also with the patient and coordinate their care. And through this process, we're able to provide very cost-effective, time-efficient care with a very low level of harm. And that's the key to screening and finding these cancers in the early stage in the workup. It's also key to getting the buy-in of the primary care providers and the physicians that order these tests. They know that when they order a test and they enter our program that they're going to be provided very comprehensive and coordinated care. And they can pretty much take their hands off the steering wheel, and we guide the patients through this process. With this foundation, we've built an extremely successful program over the last 6 years. We did 6,000 screens last year in the midst of a pandemic. We've now done 22,000 screens since we began our program in 2013, and that year we did 7 screens. We are finding 1 lung cancer for every 64 lung cancer screens that we do. And when people hear that statistic, that really is impactful. Out of those cancers that we find, we are finding 55% of them in stage 1. We're finding 69% in the early stages, stage 1 or stage 2. So we are definitely making a difference. We are causing a shift from high stages of lung cancer to low stages of lung cancer. We can make a tremendous difference. In our system, we are capturing 49% of the patients that are eligible for lung cancer screening as of last year. That compares to a national average of 6.5%. Through our process, we are expanding out and we're involved in a lot of state-based initiatives. We work with Tim Mullett and their crew at UK and the Markey Cancer Center. We've been involved in the Kentucky Leads Project. We work with the Kentucky Cancer Project, the Kentucky Cancer Foundation, and lately, over the last 2 years, we've worked very closely with the Kentucky Health Collaborative. We have Andrea Sloan and Evan Hackney here with us today as representatives. We have picked lung cancer screening as our first quality measure. And one of the most exciting things that we're doing is we have got 10 hospital systems in the state of Kentucky that collectively provide care for over 60% of our state to agree to share data. We have gotten all the signatures. It's kind of working its way through UK and the IT collecting department down there. We're literally days off of completing this process. Our state will be able to share data. We'll be able to benchmark this data. We'll be able to build quality improvement initiatives around this data and really make a difference. We'll know where the disparities lie, and we'll know how to go after them. So we are witnessing, as Tim said, a dramatic turnaround in our state. We will be #1 in the country by the end of this year. That's my bet. And we are setting the bar for lung cancer screening, for lung cancer diagnosis and treatment and management, and we are making a huge difference. We are witnessing one of the greatest turnarounds in healthcare in modern medical history, and I appreciate your help and attention.
Dr. Flora?
Well said, Mike. I'm Doug Flora. I run the cancer programs up here at St. Elizabeth over about 5 different hospitals, and I appreciate your time. And Representative Moser, thank you for the forum. I think you guys probably have recognized the passion that these two doctors speak with. And it's enlightening for the rest of us across the state to see these two not just leading this discussion regionally, but nationally. You know, Dr. Gieske is involved at just about every level that you can be involved in lung cancer screening, and is now considered a subject matter expert nationally. Dr. Mullet's been doing this for 20 years. And when you put the two of these two together, it's quite impressive for the rest of us that are sort of following in their wake. I will say, to speak to Dr. Gieske's statistics, we now have large sample sets that say that with this stage migration, you have a 146% greater chance of being found with a stage 1 when screened, and a 70% lower chance of being found with stage 4. So this is one of those opportunities for you all as legislators to help the healthcare workers here to do good while doing good. It's great for the business owners. It's great for recidivism for people taking disability. It's great for the coffers of the legislature and of the state with limited resources to take quality care of patients. And by doing this, we're sending them to Dr. Mullet, who's a heck of a lot less expensive than Dr. Flora and all of my expensive $150,000 chemo drugs. So it's one of those opportunities for the legislator in you to understand, as a parent, as a brother, or as a sister, that you can also make cost-effective and long-reaching implications with these decisions that you make today. I will say that you've mentioned appropriately that the model is set with colon. We climbed from 39th in the country to 17th in a matter of 3 or 4 short years. Our healthcare system now has prioritized that, and we're up to about 83% for our colorectal cancer screening because of the efforts of bodies like this and the outreach and education that was made available through resources that we gained from the colon cancer consortium stuff. And we're now leading the country at 49%, but that means half of these lung cancer patients never have a chance for Dr. Mullet to cure them. And so I think it's compelling. So I'll close by thanking you all for your attention. I brought out my It's a Beautiful Day to Save Lives mug in honor of these festivities, and thank you for Kim for bringing this to light.
Thank you for your testimony. We do have a couple of questions. Representative Dotson.
Thank you, Madam Chair. First of all, I'd like to say this is a great piece of legislation, but I have a 2-part question. Doctor, you said that Kentucky is #1 in late-stage lung cancer. What do you feel is the driving force behind that? And secondly, do you feel like there's any connection to the coal industry, from coal-fired plants to coal mining? Just kind of want to get your take on what makes us that #1.
Appreciate the opportunity for the question, and thank you for your support. The first part of the question, late-stage lung disease is driven by a number of factors. One of them is a culture that has been driven by years of understanding that when you find lung cancer, it's found in late-stage disease, and why should I bother? There's a bit of fatalism associated with patients, and so they are not looking for this disease. And lung cancer screening has not been on the horizon for many years. And so the culture has been one of looking for this disease is only to find a lethal diagnosis. And so many patients are not looking in that direction. Again, lung screening has not been around for many years, so we haven't had a chance to make this transition like we've seen for decades with breast cancer, with colon cancer in the last 20 years. And so I think that, and the other, of course, is that lung cancer is only symptomatic when it has already spread to someplace else. The small tumors that I take out for lung cancer that are effectively stage 1 or early stage 2 disease don't cause any symptoms at all. And so patients never know they have it. And so it's only when it is spread to someplace else that they wind up with pain, weight loss, others. The second question regarding exposure, I think, is important. The coal industry and coal-fired plants and others, there certainly is a correlation with air quality, but I think that it's not necessarily been connected with the coal industry like black lung or coal workers' pneumoconiosis is associated with that. There is a correlation, though, with population that works in the mines and with tobacco exposure. And so I think that it's difficult to dissect. There's often, of course, and Representative Birch was correct that I didn't mention tobacco. There's a tremendous amount of stigma associated with the diagnosis of lung cancer and a bit of guilt associated with the exposure to tobacco. So the opportunity to be able to dissect, separate a person who smokes from a diagnosis of lung cancer is really important, because the truth is the majority of patients, when they are diagnosed with lung cancer, are not smoking. And so it's difficult for us to burden them with the diagnosis of tobacco use when they've already made that choice to quit. So I am intentionally trying to separate those, even though it's truly the leading cause for lung cancer, but we also need to be able to have that empathic conversation with patients about tobacco use.
Thank you. Representative Westrom.
I am so glad you're here. I'm the evil person who sponsored the smoke-free Kentucky bill for 3 years in a row.
You are not evil at all.
And I've had to question myself after our meeting in Louisville this summer, talking about healthcare and the ranking of Kentucky. We virtually are the worst state as far as healthcare, personal healthcare in the country. And so after 23 years of being in the General Assembly, I wonder what the root is. Why do people not love themselves enough to take care of themselves? And how do we get them to learn to make a difference in their future, their entire life? And I would say that screening for lung cancer is incredible. It's an incredible opportunity. But I bet it's met with a lot of fear when they come in your door. And I really hope that with the success you have, there will be more people who reach out to you at an earlier stage. That'll cut healthcare costs. It'll give them much longer lifespan and give me hope to know that people are starting to love themselves enough. Thank you.
Motion on the bill. We have a motion on the bill from a second. Any other comments before we vote?
Well, if I may, I would just like to really thank my experts here today. I don't know that there's a whole lot that I can say that they haven't said and have said so eloquently, but I would just really implore everyone to support this, and certainly recommendations can be made for preventative initiatives out of the Advisory Council as well. And I would just like to thank Dr. Flora for taking such good care of my mom when she had lung cancer.
Madam Secretary, please take the roll. Yeah.
Representative Bentley? Representative Bowling?
Yes.
Representative Bray? Representative Birch? Representative Dotson?
Yes.
Representative Elliott? Representative Fleming? Representative Fraser Gordon?
Yes.
Representative Marzian?
Yes.
Representative Gibbons Prunty?
Yes.
Representative Rayburn? Representative Raymond? Representative Riley? Representative Sharp?
Yes.
Representative Sheldon?
Yes.
Representative Tate?
Yes.
Representative Weber, Representative Westrom, Representative Wilner, Chairwoman Mosier.
Yes, thank you.
Passes unanimously and should pass favorably on the House floor. Thank you all for your testimony. As the current legislative liaison to the Colon Cancer Advisory Committee, I know the great work they've done, and this probably should have been done a long time ago, but we'll move forward. So thank you all for being here today and all your work.
Thank you so much.
Thank you.
Thank you. Ooh, sorry, guys. All right. All right.
Representative Moser,
I'll just stay put.
Would you like to bring your guests to the table for House Bill 317?
I would. If my guests could please make their way to the table, we will talk about House Bill 317.
Introduce yourself for the record, and you may proceed.
Thank you, Madam Chair. I am Representative Kim Mosier again. I represent the 64th District, and I have some very great experts with me today to help me discuss what really is an update and a cleanup of Senate Bill 44 from last year. House Bill 317 is, last year we passed Senate Bill 44, which allowed charitable organizations to pay premiums and co-pays for low-income patients. And what happened last year was an amendment was placed on Senate Bill 44 that intended to prevent some bad actors from taking advantage of the system. Unfortunately, it has become clear that the language went a bit too far. It was a bit too far reaching and could have had some unintended consequences. And so we're going to talk about that today. The bill I bring before you today, House Bill 317, closes that loophole that the amendment created, but it still prohibits the bad actors from taking advantage of patients or their insurers. The bill ensures that nonprofit organizations that meet specific requirements and religious institutions can still pay insurers directly for health insurance, co-pays, and deductibles for those low-income people. This is incredibly important, particularly in our current climate during the pandemic. This is a patient-centered bit of legislation that will ensure continuity of care for people who are dealing with a health crisis. And we have some members, some guests today to talk about some of those health issues. Nonprofits and religious institutions play an important role when it comes to ensuring that low-income patients have the health care coverage that they need when they're diagnosed with a debilitating chronic disease. Not only is this important and significant as a benefit to patients, but also to taxpayers in this state, since it makes it possible for individuals to stay on their insurance and not have to rely on Medicare or Medicaid. The legislation also contains guardrails to ensure that bad actors are not able to take advantage of the system. Like I said earlier, for example, nonprofits must cover a patient's insurance for an entire year, not just a portion of the year. It has been this was an advisory opinion that required the organization to adhere to strict federal guidelines, and there are some strict guidelines that we can talk about if there are questions about those. So the guidelines that most nonprofits with patient assistance programs already adhere to, they already adhere to all of these. For example, the American Kidney Funds program guardrails are actually even stricter than what the federal guidelines put in place. We believe that what is contained in this bill is more than sufficient to protect against any fraud or any abuse, and still make sure that patients are able to receive the support that they need. So I would like to just pass the microphone off to some of my guests, and please introduce yourself for the record.
Thank you so much.
Is your mic on?
Now it is.
Okay.
Good afternoon, Chairwoman Moser, Vice Chairwoman Gibbons-Prunty, and members of the committee. My name is Melanie Lendenel. I'm with the American Kidney Fund, and I'm here today to respectfully request your support for House Bill 317, really in order to ensure that nonprofit organizations like ours can continue to help low-income patients receive the health care that they need, that they believe best meets their individual needs. The American Kidney Fund operates our health insurance premium program, otherwise known as HIP, under strict federal guidelines. And this program was approved in 1997 by the HHS Office of Inspector General, and it has helped countless patients across the country. So, for example, in 2021, last year in Kentucky, we helped 923 patients pay for their health insurance premiums. And the overwhelming majority of these patients who we helped last year, 78% of them actually chose Medicare as their choice of health insurance. The average age of our patients in the Commonwealth last year was 58 years old, and the average income was about $25,000 a year. So these are very low income patients. Additionally, we are proud to have assisted 30 of these patients with receiving kidney transplants and that surgery. Kidney transplant surgery is the best treatment option for someone who is in renal failure. This has allowed them the opportunity to resume a more normal life, to provide for their families, and of course, in most situations, to return to the workforce, which benefits everyone in the state. Our program, to be sure, is 100% needs-based. It accepts patients for grants based on a first-come, first-serve basis. And one thing that is important to mention is that patients come to us seeking grant assistance having already chosen their insurance. We don't opine nor discuss the choice of insurance. Our grants are provided to patients and only to the patients, and the grants follow the patients, regardless of where they choose treatment. So patients are never denied grant assistance from us based on where they're seeking treatment, what provider they are going to. And in fact, more than half of the providers who have patients who receive our assistance don't donate to us or our program at all. And finally, and this is probably one of the most important parts of our program, is that our assistance increases the likelihood that someone will get a kidney transplant. A patient is not placed on the transplant waiting list unless they are fully insured. And by assisting people with their health insurance, we ensure that they have the opportunity to get on the transplant list, which increases their likelihood of receiving a kidney transplant. Our goal ultimately is to create a world without kidney disease, but until that time, our HIP program ensures that patients have the healthcare coverage that they need, are able to access the healthcare coverage that they need, and that they believe best meets their individual healthcare needs. So thank you so much, Chairwoman Moser, for bringing this bill forward. We are so grateful to you and to all of the members of the committee for considering this today.
Motion on the bill.
Thank you, Chairwoman Moser and members of the committee. My name is Deb McGrath, and I'm the Executive Director of the Epilepsy Foundation of Kentuckiana. On behalf of the 173,461 Kentuckians who suffer from epilepsy, also known as a seizure disorder, who may need assistance in paying their health insurance premium, I would like to thank Chairwoman Moser for introducing House Bill 317. After the passage of Senate Bill 44 last session, we realized that late changes made to the bill would have an unintended impact on the foundation and the families we serve. The Epilepsy Foundation is a source of help for families that need assistance paying their health insurance premium. Insurance coverage is critical for this vulnerable population because not having access to their life-saving medications or physicians can have deadly consequences. The foundation has an annual fundraising event that is the primary source of funding needed to help the individuals we serve. The tremendous financial support we receive from healthcare providers who attend our fundraisers are key to the success of that fundraiser. A provision in Senate Bill 44 from 2021 allows an insurance company to reject insurance premium assistances from the Epilepsy Foundation because we receive funding from healthcare providers through our annual fundraiser. House Bill 317 would correct this unintentional exclusion so that we may continue to help families in need. We respectfully request your support for this legislation.
Thank you for your testimony. We have a motion and a second on the bill. Madam Secretary, please call the roll.
Representative Bentley? Representative Bowling?
Yes.
Representative Bray? Representative Birch? Yes. Representative Dotson?
Yes.
Representative Elliott? Aye. Representative Fleming?
Aye on this bill. I may add one thing. Please record that I am in the room, and record a yes vote for HB 188 as well as 219.
You can't do it on this vote.
Thank you.
Wait till we're done.
Thank you
and
for
then
the
I'll let
correction.
you do that.
Thank you for the
Okay.
correction. Yes.
Representative Fraser Gordon?
Yes.
Representative Marzian? Yes. Representative Gibbons Prunty?
Yes.
Representative Rayburn? Representative Raymond? Representative Riley? Representative Sharp?
Yes.
Representative Sheldon?
Yes, I'm sorry. Can I say one real quick?
Please.
Thank you very much for just this wonderful cleanup. We don't always get it right, and that's obvious sometimes, but glad that we were able to. And this really is a great example. I just wanted to point this out, that you all have contractual relationships with other people, and you have to make sure that those line up with the law. And this is a great example of where you were just really looking out for the best of the patients, and didn't really worry about all of the discussion about those contracts. Those contracts will work themselves around the law now, and that's the way it should be, to the benefit of the patient. So I appreciate that. Thank you.
Representative Tate?
Yes, if I may comment, please. I sincerely appreciate you bringing this bill forward. My father suffered from kidney disease for several years, so while he would not benefit from this, I've met several people who would certainly benefit from this bill and this initiative, and so I sincerely appreciate you doing this. So thank you very much, and I would like to vote yes.
Representative Weber? Representative Westrom? Representative Wilner? Chairwoman Mosier?
Yes.
Passes unanimously and should be favorably on the House floor. So thank you very much. Thank you all for your testimony.
Thank you. I appreciate it.
Representative Fleming, would you like to record some other votes, please?
Thank you, Madam Chair. Yes, please register a vote yes for me for HB 188 as well as 219.
Okay. Being that there are no further business, her motion for adjournment? Second. We're adjourned.